because this is also more difficult to find in textbooks and materials you have other than what is obesity. So let me start. I will jump to the next slide. In every question during your state exam, you will start with definition. What is the disease? What is it? So obesity is very simple. It's a lot of fat, excessive accumulation of fat in body, in the whole body. And even though BMI as an index is very simple, it's very stupid actually. It doesn't recognize what mass is calculated. But BMI is used across the whole field. It's used for the indication cutoffs. It's used for epidemiology. It has huge disadvantages, but because it's so simple, it's just the weight in kilograms divided by height in squared in meters. So it's so simple, it's so widespreadly used that even in guidelines, as I said, we use BMI as a definition of obesity. So everyone should know how to calculate BMI, and we should also know the normal range of BMI, which, oh, actually this slide is missing. So the normal BMI is below 25. Can you see it? Can you see my screen? Yeah, I try to share. I can see it in my window as shared. So yes. So I think it's not on my side. Maybe you need to click something else in the app. So BMI less than 25 is normal. 25 to 30 is overweight. The BMI level on the obesity severity. So that's why even these cutoffs levels 30, 35, 40 are somehow useful because we will need them later on. Pathogenesis of obesity, of course, is excess of energy in human body, which is stored as fat. Very simple. And the reasons why we have excess of energy is because we have a certain genotype, and which was made to fight against famine, and then we have an environment which doesn't quite fit this genotype. It's very simple, but I think we can stay with this. This is the idea of our genotype, because human species was kind of exposed to very long times of famine and activity, so being hungry but needed to be active. So the genes kind of follow. The genes are very efficient in storing energy and very efficient in using energy for muscle work and for producing energy from ATP. And then there were very limited amounts of time when food was available. This is the feast period, and these were cycling, during the lifespan of humans. So our genotype was a thrifty genotype, as it's actually called in the scientific literature. Because we are very, very thrifty, very efficient. However, today's humans get a lot of energy. It's very easy to find, food. We buy it in a supermarket. We don't need to hunt, etc., etc. So suddenly the environment doesn't really fit this thrifty genotype, and we go on the pathway which we are all aware of. So talking about pathogenesis and definition, very simple. Everyone, I think, will succeed in it. Something which is good to remember or refresh is that we have lipids and carbohydrates, lipids and saccharides as a source of energy on a daily basis. Usually we don't calculate proteins as a source of energy. So lipids and carbohydrates, and maybe we should remember even in the 6th year that 1 gram of lipids gives us 9 calories, and 1 gram of carbohydrates, of starches, give us about 4 calories per gram. And the rest is not necessary to remember, but you can look even in a normal individual, in a healthy individual, we have tremendous amounts of energy stored in fats. It's actually immense. We can never, under normal circumstances, it's impossible to consume all of these calories stored in fat, because fat tissue is actually the one tissue determined to store energy and to release it when needed. Just to give you a very quick perspective on the extent of obesity, we call about obesity epidemics, and it is true. Look at the prevalence of obesity in the United States in 1985. United States, because they have very nice maps which are followed up for next 40 years. So that's why I show you the map of United States. I wish we have a similar map for Europe or Czech Republic, but we don't. But believe me, the problem is worldwide. So it's not only US. But let's have a look. The blue are states where obesity prevalence, it means people with BMI over 30, obese individuals, adult individuals, are over 10% or 10 to 15% of population. So there were some states with slight number of obese people in 1985. So only not so long ago. And then look what happened over years. I will just scroll through the presentation, and now you can see the red, which is over 25% population obese. And this is 2015, which is the last slide. I didn't follow it farther, but you can see the explosion of obesity across westernized or developed countries. So it is a really significant public issue, public health issue. It is the most number one preventable cause of death in westernized countries, and this is just to demonstrate how many people are obese. So let's go farther. In Czech Republic, we have about sorry, no, I messed up with the presentation. In Czech Republic, we have about 24 to 25 people who are obese, but we don't have that nice statistics as in the United States. So our data are not that developed, but it fits with the overall obesity epidemics in the world. So why is obesity bad? Let's now go to the internal medicine. Why is it bad? Well, because it increases the risk of death quite significantly. In epidemiology, when you see a double risk of death, it's a huge increase. Even though it doesn't sound that big, 100% increased mortality is horrible. It's a nightmare for epidemiologists. So you can see that approximately from the BMI of 25, which is right here, that's the end of norm, the mortality of from cardiovascular diseases, cancer mortality, and any cause mortality is kind of exponentially increasing and ranging in doubling the mortality in morbidly obese people. So this is actually why this is a topic, why this is a concern in public health, because in theory we could prevent obesity and then we could prevent this excessive mortality. What is important and maybe good to notice is that it is a U-shaped or J-shaped curve. Also, people with very low BMI, like under 18.5 or 19, are at increased risk of death, generally speaking. So this is a J-shaped or U-shaped relationship, not a linear one. But the reason why these undernourished people have increased mortality is quite unclear. People are still discussing why is it so. Maybe it's because they don't have sort of energy stores to fight with serious disease or infection, etc. So this left part is kind of not really well explained, and we will focus on the right part, which is excess fat and excess mortality. And it's not only mortality, it's also some of the disorders you've heard about and you will include in your preparation. And if any of the disorders is literally linked to obesity, it's type 2 diabetes. It's number one pathogenic factors for developing type 2 diabetes, the diabetes in older obese adults, not necessarily treated with insulin, based on insulin resistance. You can see that the risk of developing developing diabetes is many times higher in obese. So if you are over 40 with BMI, severely obese subject has about 40 to 50 times increased risk of developing type 2 diabetes. So it's not few percent increased risk. It's the primary causal factor for type 2 diabetes is obesity. And as you know, type 2 diabetes is tremendously expensive disorder. It consumes a lot of money public health insurance, and etc., etc. So it's not only mortality, it's also some of the specific disorders like type 2 diabetes, like hypertension, which is the next slide, showing again the same story, that the higher the BMI in men and women, the higher the prevalence or risk of developing of hypertension. And I could go on and go on with these slides, showing that pretty much any civilization diseases like hypertension, dyslipidemia, and diabetes are connected with obesity. Just one slide on cancer. We will not go deeply in it, but you saw that cancer mortality is also increased in obese people, and it's not only those that one would guess because of endocrine function, like endometrium or gallbladder, but it's also some of those very common cancers like colorectal cancer or cancer of the breast. So we maybe can just remember that obesity is increasing the risk. If there will be one, simple question, how is it possible that fat accumulation leads to cancer? Well, maybe it's the whole lifestyle, of course, that people who are, more obese are not so active, and maybe the nutrition is also rich in carcinogenic compounds. But from the perspective of the human body or pathophysiology, increased levels of estrogens, because adipose tissue is actively producing and converting estrogen into active metabolites, increased levels of insulin. Insulin is a very potent growth promoting factor for any cell, so also for cells that are on the way to become cancer. Insulin promotes the growth, and then the whole bunch of other products of adipose tissue, adipokines, growth factors, etc. These are the mechanisms why cancer unrelated to adipose tissue is promoted, like in kidney or thyroid gland. So this is just to explain if someone asks how obesity can do it. And this is continuing on the explanation. We will not really go deeply into all of these molecules. It's not really necessary for clinical practice, but we can imagine an adipocyte, which is right here in the center, and the tube around it is a capillary. So there is a very tiny connection between adipocytes and capillaries, and adipocytes produce a lot of hormones and other substances which are not classified as hormones but are secreted to blood and do have impact in target tissues. And here you can see just an example. You don't need to memorize all of these molecules. There are hundreds of these molecules, but maybe we can just remember some of the pathways or some of the groups of regulations they are influencing. So of course, talking about type 2 diabetes, we will talk about many compounds produced in fat tissue regulating insulin signaling, but there are also others, immune related products which regulate immune responses, blood clotting, hemcoagulation, acute phase proteins, and of course growth factors, which we mentioned briefly for the cancer. So today we picture adipose tissue and adipocytes and also other cells which are traveling inside the adipose tissue when it's hypertrophic, when the adipocytes are very big. Other cells, macrophages and other cells migrate into adipose tissue and produce a myriad of products, hormones, interleukins, other products which are acting in distant tissues and produce the bad outcomes of obesity, if we want to say it in this very, very primitive way. So the metabolic syndrome is something I would like to cover because it's closely related to obesity and is a term which is often used and often misunderstood even at the exam. So I just want to clarify it. What is it? Metabolic syndrome is a grouping of features, grouping of findings, which are all kind of defined by impaired insulin signaling, which is equal for insulin resistance. So there is insulin on board, but the receptors do not transfer the signal to the cells, to the muscle cells, to liver cells, to cells, endothelial cells, etc. So the body, the cells, and the human body is insulin resistant. And the features which are consequent of insulin resistance are marked here. So it's, as I said, endothelial dysfunction, polycystic ovary syndrome, impaired glucose metabolism, increased blood pressure, impaired fibrinolysis, and this all can be named as a metabolic syndrome. But as you can imagine, there are so many features that people would not understand each other. What do you mean if you say in metabolic syndrome, do you mean endothelial dysfunction and hyperuricemia, or do you mean visceral obesity and hypertension? So there will be a huge confusion. So that's why experts actually made a meeting and defined what is considered as a term metabolic syndrome. And here comes the problem, because the experts met, many times, so they spit out many different definitions. But from 2005, which is a long time ago, it's already 15 years, they agreed. This is the IDF definition in the red box. Says that metabolic syndrome, in medical terminology, when the doctor says metabolic syndrome, the patient needs to have increased waist circumference. The patient needs to have big belly, waist circumference. We will talk about it in a second. What are the measures? But increased waist circumference, abdominal obesity, in other words, abdominal obesity, I will explain in a second, needs to be present for someone to be classified as having metabolic syndrome. And then two of the other features which are listed below, which means higher triglycerides, low HDL, higher blood pressure, or higher glucose than normal, or treatment for these disorders. Of course, if someone takes medication, the blood pressure measured in the office is normal, but we classify it as having hypertension because the patient is treated. But the key feature, the new key feature, is that the abdominal obesity needs to be present, and then we need to list or find two of other features listed here: glucose, blood pressure, lipids. That's it. And the other features which we showed here are all true, but they don't qualify to be a diagnostic criteria. So if you go into the problem of metabolic syndrome, if you mention it, maybe we will ask you, what do you mean by metabolic syndrome? You should really provide us with the definition based on the IDF criteria. And the reason why metabolic syndrome and why abdominal obesity is so put forward, is so emphasized, is that the distribution of fat, not only the total amount of fat, not only BMI, but also distribution of fat, is associated with lower or higher risk of cardiovascular diseases. And as you can imagine, the fat which is really dangerous, which is more metabolic active, which produces more of the bad adipokines, bad hormones, and bad substances leading to cardiovascular diseases, atherosclerosis, heart failure, hypertension, is the fat located in abdominal cavity, around omentum, in mesenterium, inside abdominal cavity, and it's from the outside, it's measured by waist circumference, as is shown here. So subjects who have high waist circumference, who have abdominal obesity, are at higher risk of developing cardiovascular diseases, as is shown on this lower part. While we sometimes refer this androgenic obesity, because this is obesity typical for males, for men. In contrast to gynoid obesity, or the obesity which is, if you calculate BMI, you will have high BMI, 35, 32, but the fat is distributed in this gluteofemoral region and not really in abdominal cavity. So the waist circumference is actually not enlarged or not that much enlarged, and this fat in femoral and gluteal region is not actually associated with increased risk, because, as I said, more dangerous is the fat in abdominal cavity. So this is why we focus so much on waist circumference, and we measure it repeatedly. We measure it in every patient in our diabetology practice, but also obesitology practice. And what we want you to remember is the normal values, because they are quite strict. In men, it's 80, it's 94 in men, and it's 80 in women. Waist circumference. So these two numbers, please remember, because even if you get obese subject for your practical exam or during theoretical exam, this is what defines abdominal obesity. This is what defines metabolic syndrome. So it's quite strict. 80 centimeters waist circumference in women, and 94 in men is the upper limit of norm. So that's waist circumference, metabolic syndrome, abdominal obesity, terms which are closely related. So now what to do with a patient who is obese? We have about 20 minutes to discuss this. So there is nothing really, amazingly different than from the physical examination of other patients. So you go through the family history, but maybe you focus more on something which is not so important for other disorders, which is, we ask about eating patterns. What is your typical eating pattern? Do you eat, in the morning? Do you have breakfast, or do you more have the more calories taken in during afternoon or night? What are your eating patterns? What are your eating behaviors? We also ask about family history, of course, of obesity. I skipped this for this lecture, not important, but the genetic component is about 40 to 60%. So obese parents have, or kids of obese parents have higher likelihood of developing obesity, because there is not only lifestyle, but also a huge contribution of genes, ethnicity. Certain ethnic groups are more prone to obesity in the same environment than others, right? So this all goes about the genes and about the history. We also ask more specifically, and we should note it, what are the physical activity patterns? Is the subject, it doesn't mean that obese people are always sedentary. It's not the case, right? It would be a prejudice. So they sometimes, some of them are active. So we record how often, how much, how often, what is the intensity, what type of exercise, what do you do, and we will note it in our files, in our physical exam and family history, etc. Part of the medical documentation, and we also ask about the patient expectations and motivations, because imagine you are treating these patients, right? We are now physicians treating these patients, and it matters a lot. It matters a lot how the patient expects, whether he or she came to ask you for help, or whether someone sent him or her just to check out the box that she or he visited specialized care, but the patient himself or herself is not actually motivated to do anything. A huge impact on the success of treatment. Oh, sorry, I had another slide here. Here it is. So from the physical exam, now we're going to physical exam. We do everything as we are used to. We do full physical examination from head to toe, but what we should never forget is measure weight and height, because we calculate BMI, right? That's our number one number, because we need to know BMI to classify the subjects. And then, as we already discussed, we need to measure waist circumference to classify whether it's obesity, whether there is abdominal obesity or not. And we will also look for signs of other comorbidities which we know are associated with obesity. So we will look for example, signs of NA and fatty liver, which means increased liver. We will examine maybe more closely joints, especially on the lower extremities, whether there are no signs of severe arthrosis, because it also is annoying to people. It's not internal medicine, of course, but for the life of patients, the joints affection, the hip and knee atherosclerosis is a huge impact, right? We will also investigate cardiovascular system, murmurs, etc. Sleep disorders we can ask about sleep. We should ask about sleep, because obstructive sleep apnea is present in many obese people, like 60-70% do not have good sleep. They desaturate during sleep, and there is a specific treatment for it. So let's ask about it. From the lab test, standard lab testing, as you know, you will be very interested in fasting glucose and lipid levels, because this will help you to classify whether the patient has or doesn't have metabolic syndrome, right? 3 of 5 features which we named: glucose, lipids, hypertension, and waist circumference. So you should actually cover these in your physical exam. Okay, so we have a patient who came, we understand what are the expectations, we did a physical examination, and now we need to set some goals for the treatment. And this is another take-home message. You will be surprised that the initial goals for weight reduction in obese people are actually quite low, right? 5 to 10% of initial body weight. It's not much. It's 5 to 10 kilograms, maybe even less kilograms in more obese people. So a few kilograms of weight loss, actually, which I try to show on this slide, has evidence-based data that it helps. Even 5 to 10%. And this is why it's in the recommendations, because it helps, it has a proven benefits, and it's achievable. Patients can achieve 5 to 10% weight reduction by the means which we will discuss in a second. So it's achievable. So perhaps the patient will be motivated, right? If the patient sees that it's working, now she or he lost 5 kilograms, and my physician is happy with that. And not only physician, but the human body is happy as well. The blood pressure will decrease, blood lipid profile will be improved, insulin sensitivity and glucose control, glucose levels will be much improved even after such a moderate or minor weight loss, and all the other inflammatory markers, the level of blood clotting mechanisms, the risk of blood clotting is decreased. So overall, the cardiovascular risk is decreased even after such a low weight loss. And I have another slide looking how moderate weight loss, 4.5 kilograms only in these obese individuals across a couple of weeks, led to 30% reduction in diabetes, type 2 diabetes presence or prevalence. So you can see that really moderate weight loss is effective. There are data for it. The recommendations say we should, as a first line of treatment, suggest this achievable goal, because it brings benefits. So what should we recommend to achieve this 5 to 10% weight loss? Of course, you all know it. It's diet, it's lifestyle, right? Composing of diet and exercise. But I would like you to know a little bit more than just saying diet and exercise. So what are the key principles of diet and key principles of exercise we prescribe to obese individuals? Because you need to give patients some specific advice, right? You cannot just give him advice, eat less and exercise more. Every person is different. So the principles of diet, and I understand especially diet is a very controversial field. There are various types of dietary approaches. Most of them work. But we need to start with something, let's say, which is set in stone, and then we can, find deviations. So the basic feature is that the diet needs to be low caloric. We need to cut calories from the daily need. The daily need we calculate maybe by Harris-Benedict equation, which you probably are familiar with. If not, it's written down here. You can find it on internet. It's quite precise. In otherwise healthy individuals, you just get what is a basic metabolic rate, and then you add some 15-20% on top of this calculated basal metabolic rate for daily activities and so on. And then you have a number. Let's say the number is 2,000 calories per person. You calculated that from Harris-Benedict equation. So you remove 600 to 800 calories, and that is your caloric goal for the day. So let's assume that for me, for example, it will be, let's say, 1400 calories per day will be my diet, right? Specific advice: eat 1400 calories per day. Watch your food and eat 1400 calories. How to achieve it? The easiest way, even though I understand there are other ways, there are low carbohydrate diets, ketogenic diets. Everything is fine if you can, provide the reasoning, I'm fine. But the easiest way is just to cut fat, because fat is rich in energy. So low fat, low caloric diet is a cornerstone of dietary intervention, even though other diets possible, as long as they are low caloric and provide all the other nutrients, we are fine. Another very important feature is fiber. We all should eat about 20 to 40 grams of fiber. Very difficult to achieve, but this is the recommendation, and it helps, especially in dietary interventions, in weight-losing interventions. It helps because it induces satiety, the feeling of satiety. The volume of fiber, as it expands, gives the feeling of satiety and prolongs the possibility of fasting in subjects. It actually makes it easier and more successful. Sometimes people ask about the cocktail diets, Ultra, Eat and Lose, and many other commercial products, literally meaning you substitute a meal with a liquid cocktail, which is typically based on proteins or on egg or whey proteins. The advantage is that you easily cut calories. That's true, because these very low caloric diet, VLCD is a very low caloric diet, providing only about 600 calories, 800 calories per day. so very little calories, have some advantages. It's easy, you just drink a cocktail, you're done, you don't need to cook, etc., etc. Women typically like it, but its usefulness in the long term, you cannot drink cocktails for the rest of your life. So the position of cocktail diets, very low caloric diets, is from the global perspective limited. We can maybe suggest substituting one meal a day with this, maybe the lunch, and then have a dinner with the family, etc. It depends how you will discuss it with your patients, but having patients on full cocktail diet is not really recommended and is reserved for specialized care and for short term, maybe to motivate them, break some resistance, etc. So just to know about very low caloric diet. So again, basic principles of exercise. What should people do? People should do exercise which helps them to burn calories, right? And especially burn fat, because if you have, for example, high intensity exercise, people burn calories, but most of these calories are from carbohydrates. So that's why the recommendations are actually light to moderate intensity exercise. What does it mean? It means the exercise when people can talk. You can talk in sentences. That is light to moderate intensity, very generally defined, but usually working. So it's typically walking or any, walking is the best. It's most physiological because everyone pretty much can walk, or maybe some bicycle ergometer training at home. We can also talk about other options like swimming or really cycling, but these have some concerns, right? Swimming, they need to travel to a swimming pool. It takes a lot of time. Cycling on the road is probably not very safe for elderly, obese people. So there are some caveats, but at least we should remember it should be light to moderate intensity. If patients try to exercise more at moderate to heavy, they don't burn so much fat. They burn calories, they produce cardiovascular benefits, they improve blood pressure, but they don't lose so much fat because fat is burned at lower intensities. And also because of we are burning fat, we need to start lipolysis. We need to start degrading fat from triglycerides, fatty acids, and fatty acids needs to be used in muscle and transported. It takes time. It doesn't happen in seconds. So the exercise session needs to be at least 45-60 minutes of light intensity. It's more about the duration than the intensity because it takes time. It takes time for the catecholamines to inform adipose tissue. They should activate hormone sensitive lipase, and fatty acids needs to be released. It takes time. So we should have at least 45 to 1 hour sessions for exercise. So we have basic principles of eat more and eat less and exercise more. Just basic principles. If you have your favorite diet and you can provide valid data, valid reasoning, it's fine as well. There are, of course, many tools that help patients achieve what we just discussed. So there are many apps on pretty much any watch we have right now, help people to monitor how much they walk, how many calories they spend. There are also different caloric tables where people can enter what they eat, and the mobile phone, cell phone counts calories, composition, saccharides, very full. I use this with my patients, and some of them really like this caloric tables app in the phone. There are also other applications. For example, this plate system, very useful as well. It's a printed version. It's printed cards actually, and it works in a way that you inform the patient that he or she can eat 15 plates a day. Any plates. 15 plates makes you 6,000 kilojoules, which is 100 calories. So the patient actually, and this is a small booklet. It has about 15 pages with these pictures, and any plate. You pick up any plate, but if you pick up the plate with mozzarella, you have only a very little of mozzarella, right? But that counts as one plate. Or you can choose to have a plate full of paprikas or lettuce, etc. So very easy for a patient. Patient doesn't need to count, on a paper calorie, this many and that many calories. He looks at the picture. This is my one plate. I can eat 15 of these per day, and then make your choices, right? Some of the plates are labeled green. Those are preferred. Some of them are labeled red, not forbidden, but not so good from the composition part, right? Red is, for example, this tavený syr, this cheese, which is eaten, I guess, only in Czech Republic, which is very rich in fat and salt and so on. So there are tools to help patients live with this and achieve the goals doesn't necessarily need to weight food. Every portion doesn't need to be weighted and recorded in a paper, right? No one will do it in a long term. We have modern applications. So general advice for lifestyle summarized here: eat less energetic food, avoid any energy containing beverages. That's completely, nearly forbidden, so to say. Decrease amount of portions, include breakfast, very important. Including breakfast has been found repeatedly as a risk factor or helping factor number one. Breakfast really helps to control the food behavior during the day. So what I want to add on is pharmacotherapy and then surgical therapy, because you'll be doctors, you should know also about drugs which are available and procedures. So what we have in Czech Republic and in Europe, generally speaking, in Europe, what is available? It's slightly different than from the US market. The US market has some other substances which are approved in US, but were not approved in Europe. So I'm just saying, in case some of you are from US, you have more options. But in Europe, we have option number one. The most modern one is this GLP-1 agonist. GLP-1 agonist from the treatment of diabetes, type 2 diabetes. It's true. They are used for treatment of type 2 diabetes. And as a side effect, they have weight loss. So the company decided, okay, we will register this compound as anti-obesity drug, also in patients who don't have diabetes, right? So the drug is called Saxenda. It's a commercial name. Liraglutide is the name you know from treatment of diabetes. But in this case, in this scenario, it's used for treatment of obesity, because what it does, it signals to the brain, to the GLP receptors in the brain. So it decreases satiety, and it also induces a little feeling of nausea or fullness, right? Because GLP-1 is also receptors is also functioning on the GIT movement, on the stomach movement and bowel movement. So when you inject it, it actually causes it slows down gastric emptying, and it induces a little nausea. So it's a double effect. One is a central effect, anorexic effect in the brain, don't eat so much. Another effect is in the stomach, because the people get let's say moderate or controlled nausea. So liraglutide is the last one, or the first one, the most modern one in the row of possible medication. It needs to be injected. That's the only disadvantage. As other GLP-1 agonists, all of them need to be injected. Then we have other drugs. One of them is for a long time on the market. It's orlistat. It's the inhibitor of gut lipases. So it inhibits the digestion of lipids in the gut. So the fat goes farther in the gut to the to the bowel, to colon, and then the microbes digest on it, and they degrade it into smaller fatty acids, which induce diarrhea. So not only that the fat is not ingested, it's ingested, but it's not absorbed because it's not digested. The enzymes are inhibited, and they continue to travel, and then the patient also gets diarrhea. So it's like a self-educating approach that the patient naturally avoids fatty food, because the fatty food in combination with this drug cause diarrhea, which people don't like to have. This is over-the-counter prescription. You can buy it over-the-counter as Ali or Xenical. It's possible to buy it over-the-counter. Another combination, quite novel drug, which is as a tablet. So liraglutide is a novel one as an injectable. Bupropion, naltrexone, or Mysimba as a commercial name, is a drug which functions as an inhibitor of hunger. It's a anorectic drug which induces anorexia. It decreases the hunger, the appetite in the brain by modifying serotonin and noradrenaline and other. It's a complex effect, all mediated by brain and by neurotransmitter uptake and modulation in the brain, leading to decreased hunger. So these three are really used very often and available for each of them is paid from the public insurance. Phentermine is below the line, or Adipex. Phentermine, it's a stimulant. It's a stimulant similar to other drugs. to amphetamine drugs, similar structure to amphetamine drugs, and because it has been used and abused by drug dealers and people dependent on drugs, it's now it's not prohibited, but you need to write it on special prescription. It's followed up, so it's just existent but not really used. So remember, liraglutide, orlistat, and bupropion naltrexone as a combination drug for obesity treatment. Who is available? Who is not available, but who these drugs are available for? So it's for everyone who is obese, actually. So everyone who has BMI over 30, and because we know that many people who are not obese but are going to be obese very soon, it's also allowed or approved to use these medications in people who are in the middle, BMI of 27, and have some other disorders like diabetes, dyslipidemia, hypertension, arthrosis. So these people can be like artists treated even with BMI of 27. And you should always assess the effectiveness if the patients taking medication, but maybe it doesn't work. So if after four months there is no weight loss, they say at least 5%, but some weight loss, you will probably discontinue using these pharmacotherapy. I will skip this because this is something I usually show to students. We are short of time, but what happens? Any combination? Yeah, you can give combination. Very good question. Sarah asked if we give combination of drugs. Yes, we can, because we combine different mechanisms of action. So we will probably combine liraglutide and orlistat, or orlistat and bupropion. That's good because these mechanisms are different. So very good question. Thank you. We do combination. So this is what happens in the long term. After long term, after 2 years, these people lost weight after half a year, all of them, after six weeks, actually, no, half a year, sorry, 6 months, they lost weight either by exercise or diet, doesn't matter. But after 2 years, sorry, all of them, most of them, not all of them, but most of them, 2/3 of them to be specific, regained the weight. So it's not so much today a problem of losing weight. It's more a problem how to prevent weight regain or have the weight loss sustainable for a long time, not only for a few weeks or even few years. We want a life-lasting intervention, and the life-lasting intervention, and this is my last topic to cover, is bariatric surgery or metabolic surgery. So it means maybe more aggressive approach, but it's a standard of treatment. It's not some extravagant ideas. These are covered by insurance companies in Czech Republic. Differs in different countries, of course, but these are standards of care. I just want to take home message that bariatric surgery, metabolic surgery, is a standard of care. It's available to any patient who is indicated and who is eligible. So just to have some, again, basic idea, what is it? What does it mean, bariatric surgery? We have two types of operations. One of them are called restrictive procedures, basically making smaller stomach. The number one procedure today is gastric plication. So this is the middle picture. Means the stomach is kind of wrapped inside and then stapled with a stapler, making a small tubular stomach. So when people eat, they feel satiety very early. They are full very early, so they stop eating and they induce weight loss because of restriction. So these are restrictive operations. Adjustable bending, which is the left, was the first one which was introduced, but it's less efficient. And today we prefer, and numbers say that today number one is this plication. Another type of operation, as a group of operation, is malabsorptive operations. So here you can see, and number one is gastric bypass, or synonym is gastric bypass. So what happens here? It's more invasive operation, because what happens here, that when the patient eats, actually the food doesn't go into stomach. The stomach is interrupted right here, but goes directly into the middle portion of the gut, and it's not digested, right? Because no digestion juices or fluids were mixed with the food. So the food is not digested and meets right here, meets at quite distant part, meets with the pancreatic and the bile acid juices, bile juice, but bile and pancreatic secretion, and there is only a limited amount of gut terminal ileum, which serves as a space for digestion and absorption. So what we induce by this gastric bypass, we bypass the stomach and put the food directly into distal parts of the gut. What we do is a malabsorption. Of course, it needs to be done in a regulated manner so that we don't induce dangerous malabsorption. But the idea is to induce malabsorption and this way induce weight loss for extended period of time. So we have restrictive and malabsorptive approaches. We will not go into greater detail here because otherwise, we will lose a lot of time, and it's not important for right now to understand all the details of these operations. There are specialized centers which do these operations. So for our task, even our task as a diabetologist, is to educate people well, show them advantages, disadvantages, and I will ask there are a couple of questions which came. All of them are interesting. I will answer to them after 3 minutes because I'm finishing with the presentation. So just hold on. So there are specialized centers who do these operations. So you need to provide the appropriate referral, explain the patient, benefits, risks, what can be expected with operation, without operation, what are the risks which you just see. Right now I'm showing you the mortality and morbidity risks. So it's not a risk-free operation, of course. Look at the application. So in application, you can expect 25% weight loss, but you have some very limited mortality, but there is mortality. And it's at the level of planned laparoscopic cholecystectomy. So the application, everything is done laparoscopically today, all of these operations. Mortality and morbidity is similar to laparoscopic cholecystectomy. So, not zero, that will be not fair, but not, tremendously dangerous. Of course, for the bypass, you have more weight loss, quite understandably. It's, more severe operation, but also you have more 2.5% of serious, 10% of any complications. So there are some surgical. This is meant surgical and early post-surgical complications. And of course, for any of these operations, the subject needs to be followed up in a specialized or less specialized, but still followed up in centers who understand, looking for, especially in malabsorption, vitamin D, calcium, iron, B12. All of this needs to be, taken care of. So it's not for everyone, right? It's not for, just sending any patient go to bariatric surgery. There is an age limitation. About the age, we are not, quite sure as a scientist. Maybe 65 is still quite good. We don't have data. We don't have data showing that 75 years old people benefit from bariatric surgery, right? That's why the age is, 18 to 60, 65 maybe. It's for everyone who has BMI over 40. So if BMI is over 40, and you can, at least give a patient a brochure or, have a small quick intervention, five minutes talking about possibilities of bariatric surgery. If the patient has some other comorbidity, diabetes, cardiac compromise, infarction, after infarction, has higher blood pressure, has arthrosis, has sleep apnea, then you can indicate, and the insurance company will pay for it. If the BMI is 35, and if the patient has type 2 diabetes and is maybe younger, motivated, you really see that the bariatric surgery will be a big benefit, then you can do it also in type 2 diabetics with BMI over 30. So, it's a big table. I know you need to remember many other tables. This is not absolutely, kind of required for your exam, but maybe if you remember, it's from the middle-aged obese kind of, people with obese BMI over 40, and some exceptions allow even at lower BMI. I think that's fine because there are some exceptions, and if you need this information, you will look into guidelines, right? And interesting is that you can consider any BMI throughout the life. So if someone was very obese 10 years ago or 5 years ago, BMI 42, right now the BMI is 36, but is not moving lower, you can do bariatric surgery because it was 40 in before. And this is my closing slide, this and next one, and then I go to questions. I know we are a little over time. So what are the effects? Look at it, percent weight change, and on the x-axis, years, 20 years, right? Follow-up of 20 years. Again, I say these are not extravagant novel procedures. These are known for 30. This is one of the big studies. Look at the weight loss, definitely 25, 30%. The green line is gastric bypass, the more serious. The red line or purple line is application. So you can see that the weight loss is significant and is sustained, right? Over 20 years, people still have detectable significant weight loss, and it's reflected in mortality, right? Mortality, weight loss, okay, interesting, but do people live longer? Yes, they live longer. They have about 30% decreased mortality, and they have less myocardial infarction and less cancer. Again, 16 years of follow-up, any surgery versus control. So it has an effect. It is useful. It is useful for anyone who is obese, and it's mega useful for people who have type 2 diabetes and are obese, because look at this: diabetes remission. It means the diabetes disappeared, right? Disappeared after bariatric surgery in about 70% of people, if the operation is done early enough in the progress of diabetes. So it means we should not hesitate. We should really do the operation quite early, especially if the patient has diabetes, maybe the first year, second year after diagnosis, because then really the diabetes disappears. People are without medication in 70% of them. If we postpone it, if we do it after 15 years of diabetes, then the effects are much smaller. But we don't going to talk about diabetes today. You will have another lectures on diabetes, so I can skip this and just conclude and go to questions. So conclusion: have realistic expectations. 5 to 10% for everyone. Maybe for someone who is diabetic and you want to change the life 180 degrees, then bariatric surgery with, of course, bigger expectation of weight loss. Prevent stigmatization. We didn't have time to talk about it, but imagine that obese people are stigmatized from the society, generally speaking, and we should not promote it as physicians, right? So we should treat it as a disease, as any other diseases, and be very, very professional. We need to be not only physicians and educated physicians. Treating obesity is very difficult. The outcomes are sometimes worse than treatment of many cancer. Many types of cancer have better outcomes than treating obesity, in 10 years kind of perspective. So this is for conclusions, and now we have a question. Question from Vitaly is: to what extent should we be aware of pharmacodynamic of the drugs? Well, it's a very, very good and very difficult question. Of course, when you combine any drug, you need to take into consideration the metabolism and so on. But on the other hand, I said that we will combine this with the orlistat, and orlistat, I didn't mention it, but orlistat is inhibitor of gut lipases, and it's not absorbed in the bloodstream. So orlistat, this Ali, this Xenical Ali over-the-counter preparation, inhibits gut lipases, but it stays local. It stays in the gut. It doesn't go to the blood, so it doesn't need to be metabolized in liver. And you have you have one less thing to worry about, because drug interactions, metabolism in liver, etc., is not a concern because it's not metabolized in liver, right? But otherwise, obese people, typically people with type 2 diabetes, they have many other drugs, and I advise you to consult some of the online instruments where you can download or choose the drugs, and it will give you the list of interactions, because none of us is able to do it for more than two or three drugs. On the other hand, these are not the drugs which will be very prone to drug interactions, right? The patient needs to be tested by psychologists. He needs to prove some weight loss himself or herself. They need to prove they are able to adhere to the lifetime limitations. So it's a complex process. It's a complex discipline in medicine. But what we do, we indicate the patients. So we don't do the surgery, but we indicate, we talk with the people. This is option for you. Most of them, of course, refuse or are not interested, or it seems too drastic for them. So very few patients actually accept it. But if they do, we refer them to the place where this is the number one interest of them. So that's it. So from my part, if you have any other questions, just feel free to write it to the window, and I will try to answer. If you don't have questions, this web application doesn't let me to share my presentation with you. But what I will do, I will check if it's on Viewka. If it's, I will stop the sharing. I'm still online, and I will check right now if it's in Viewka. It should be there. If it's not there, I will make sure to upload it there tomorrow or today or tomorrow latest. Right. So don't worry. You will have this presentation to go through some of the details if you need available on Viewka. It just takes a little notice. Okay. So I thank you. I don't know exactly what will be the faculty or university recommendations for seminars and lectures. It changes every day. We are also learning, but somehow we will try to Mana, yeah, Samuel, we will try to deliver you distant education through one of the possible ways. One answer is if Mana is recommended one of the cocktails. Mana actually is a different type of cocktails. Mana is a full spectrum nutrition, and it's not so low caloric if you look at Mana. So in my understanding, Mana is more like I don't know, healthy or possible substitute for unhealthy snacking when you are on a travel or going to the mountains or I don't know, whatever. But it's not a low caloric protein based cocktail. These are usually protein based cocktails. Keto diet, for example. Right? I don't want to promote any commercial product, but in Czech Republic you can buy Keto Diet and many other produces, which make it that the one serving is very, very low caloric, usually about 100 to 150 calories in one serving. So one meal is only 150 calories. You eat 4 to 6 of these meals per day, which gives you those 600 to 800 calories per day. It's a huge restriction. It's significant caloric restriction. It usually works. People can eat vegetables on top of it. They don't count vegetables, but otherwise only this cocktail nutrition. But the problem is, what will you do after, right? What will you do after those 2 months? Okay, you will do this for 2 months with someone, 10 kilograms lost, but what then, right? What will be the next step? So it's not self-treating. It's not recommended to have people solely on these cocktail diets. You can incorporate it. I often do it because for lunch, typically for women, for lunch, it's not a big deal to substitute instead of lunch. They will mix this, soup. Usually it's in a form of soup, but they also have some form of some small like pancakes or different or yogurts. So they eat this. They have lunch coverage. They saved a lot of calories, and then usually for the dinner they need to have the social interaction with family. So usually it's easier to take these cocktails for lunch, and that's fine, and that helps to cut calories. So yeah, but Mana, I think Mana, you can look, I don't know it off my head, but you can look at the composition. Mana will have many calories per serving. Okay, guys, so any other questions related to obesity or anything else? Feel free to ask. If you have any feedback about, I know some of the feedback about the functioning of different systems, but if you have your own feedback, write it to, probably you can write it to me, but you can write it to Prodekan Marks. We have a Dean's Collegium tomorrow, the Dean's board meeting, and we will discuss what should we do with the online education. So feedback is welcomed. I know that Adobe crashes many times, so it's not probably the best one, even though it's nice. It doesn't work. People cannot log in. If you like this one, just provide some feedback in emails, me or to Dr. Marks, and maybe this will be the platform. Who knows? All right. So I will, if there are no other questions, I will log out, and I think that will terminate your session as well. I wish you all the good luck and stay safe. Bye bye. Bye bye.
No, Honzo, ahoj, tady Tomáš Kostrhun.